welcome to this evening's talk, which is the fourth of the Scottish Dementia Research Consortium webinar series. I'm Dr. Maggie Ellis, and I'm a senior lecturer in psychology at the University of St Andrews, and all my research and teaching is on dementia. I'm also part of the executive committee of the SDRC, Living with Dementia theme, and I will be chairing this evening's webinar. It's my great pleasure to introduce our speaker this evening. We're very lucky to welcome Professor Alasdair MacLullich from the University of Edinburgh. Professor of Geriatric Medicine, Alasdair's main research interests are the clinical assessment, neuropsychology and pathophysiology of delirium. Alasdair's a world-leading expert on delirium, and this talk provides information on what delirium is and what its relationship to dementia is. Alasdair's talk is called Why Dementia Researchers Need to Know a Lot About Delirium. And if you have any questions, please keep them to the end. I will hand over the floor to you guys at the end once we've let Alasdair talk. So over to you, Alasdair.
Thank you very much. Can I just get a quick check that you can see my slides?
Yes, can see.
Great. Well, thanks very much to Terry and the board of the SDRC for inviting me. It's a great pleasure and a privilege to have this chance to engage with Scotland's dementia research community. I've been to a couple of the SDRC meetings, which are always really amazing, and a huge diversity of work going on. I want to apologise a bit for the title, which was perhaps done in a little bit of haste. But I do think seriously that the field of delirium is too separated from the field of dementia. People in delirium know all about dementia because it's just an inherent part of what we do, but I think that we really need to expand the research capacity in delirium, and I think one way of doing that is to just have it more incorporated as a normal part of dementia research. So hopefully I'm going to be making a bit of a case for that in this talk. So I'm just going to start with a few slides on the background on what delirium is, what we do to look after it, then move on to the second half of the talk, which will cover delirium and dementia, epidemiology, to start with, and then some ideas around the mechanisms linking the two, some implications, and then some conclusions. So just a bit of background on delirium, because I'm sure that some people will know about it, but maybe not everyone in the audience is familiar with delirium. So essentially, it's an acute deterioration of mental functioning, and it really distinguishes this from dementia in the sense that it occurs over hours or days. It's very severe in most cases. It's a large change in somebody's ability to think, concentrate. Often they can have psychotic features. Around a third to a half have paranoid ideas or can see hallucinations. There can be mood changes and so on. So it can be quite a heterogeneous syndrome, but it's very dramatic usually, and it changes the ability of somebody to be able to function normally in a very clear way usually. And delirium is usually caused by some kind of medical illness, a pneumonia, urinary tract infection, an injury like a hip fracture. Often it's caused by drugs, either a new drug being introduced or too much of a drug being given, such as morphine, dihydrocodeine, tramadol. These are kind of notorious causes of it, but also a sudden withdrawal of drugs can cause delirium too. Surgery can cause it. So essentially you're looking at anything that can upset the brain can, in vulnerable people, lead to delirium. And one thing I want to point out at this stage is that Ken Rockwood, who's a well-known geriatrician who's worked a lot on dementia, delirium and frailty, memorably called the situation around naming delirium terminological chaos, with all those different terms, and subacute befuddlement being one of my favorites, pump head, which occurs after coronary artery bypass graft surgery, ICU psychosis, all these different terms, which essentially are all referring to the diagnosis of delirium. So I'm saying this in case you happen to be reading papers where these kinds of terms come up. Anything that's that's stating that it's acute, that there's been an acute onset. Really, it's delirium. It's just that we've had a real problem in the field of having a consistent policy around naming. Another thing that's really important to understand is just what a big deal delirium is in terms of healthcare. So in the Royal Infirmary where I work in Edinburgh, around a fifth of people, that's 200 people in the Royal Infirmary, will have delirium at any one point, 150 maybe on good days. In the ED, older people, around a third have delirium. Lots of people with hip fracture get it too, around half in the intensive care unit, and around 50% in palliative care settings too. Delirium is strongly affected by background risk. Old age and dementia are by far the most important risk factors. Frailty is also quite important, comorbidities and so on. But I'd just like to emphasize that dementia is a very important risk factor for delirium. It used to be thought that delirium was quite a transient and benign condition, and that thinking was just wrong. Unfortunately, it turns out that independently, delirium contributes to multiple poor outcomes. Some of the acute ones are listed on the left. So people with delirium have about twice or 3 times the length of hospital stay on average. They've got much higher rates of mortality. 1 in 6 people with delirium, unfortunately, are dead in a month in most studies, especially in the older age groups. People with delirium can't look after themselves properly, so they often get dehydrated if the care isn't good, and so on. On the right, there are some longer-term outcomes which have been well documented in multiple big studies now. I'm going to come to the risk of future dementia later. It's also a very distressing condition. I'm just going to give you a few seconds to read this slide. So this is one of multiple accounts that are now in the literature and online where people talk about how bad it was to experience delirium. This is another person who had delirium who wrote this during the episode. And this experience of extreme disorientation and distress and unfamiliarity with what's going around them is commonly described. So now I'd like to move on to just a general discussion, quite brief discussion around what is understood at the moment as to what the mechanism of delirium might be. So I was asked this question as in a public engagement event, and I think this is a really good summary of a question trying to get at what is delirium about. So why does a urinary tract infection make my nan go loopy, doc? And that's just not really known. But I'd like to just try and break it down into a basic cartoon of what delirium might be and how, in terms of understanding its mechanisms. So on the left, we have all the potential causes, acute illness, trauma, and so on. And these somehow, in vulnerable people especially, can lead to forms of acute brain injury, likely different kinds of forms. And then this acute brain injury leads to the behavioral syndrome that we see. And I think this is something that's been missing from the narrative around delirium, has been that it's at the heart of it is an acute brain injury. I think it's kind of been dismissed as maybe a mild neurotransmitter change or something that's inevitable with aging, but actually it has to be that there's a substrate underlying delirium, which, as we'll see with respect to the epidemiological data linking delirium with dementia risk, is probably in many cases going to be linked with really severe brain injury that leads to bad consequences in the future, not just the delirium itself. And I quite like to break it down into 2 broad streams: direct brain insults and aberrant stress responses. And I'll just describe these briefly now. So direct brain insults, and these kinds of things will be familiar to anyone who works clinically, that people in hospital very often have low blood oxygen. This happened a great deal with COVID, where people who were sick enough with COVID to come to hospital had serious pneumonia. And we saw lots of severe hypoxia in these patients and rates of delirium of about 40%, at least in people with COVID, unfortunately. Low blood pressure, hypotension, low blood glucose, hypoglycemia, and so on. And so there are really multiple threats to the brain when somebody is sick in hospital, especially if they're old. with many possible ways that this could be leading to a delirium. However, we do see patients with delirium who don't have obvious big physiological reasons for the brain not working or new drugs or anything like that. And this is another stream or channel by which delirium can arise. And we think that probably a lot of this is due to broadly termed a stress response, and this could include inflammation, with a lot of research now on excessive activation of microglia, leading to pro-inflammatory cytokines being released and injury to the brain, or, for example, prolonged exposure to cortisol. So in summary, let's firmly place in our minds the idea that delirium, yes, it's a behavioral syndrome, that's how it manifests, and that's what we see in clinical practice, but underlying it is an acute encephalopathy, an acute brain injury with multiple potential mechanisms. And the triggers can be obvious, hypoxia, hypoglycemia, and so on, but in many cases, we don't really have a clear pathway other than a trigger and then something going wrong in somebody's behavior, but we don't know why exactly that's happened. Possibly this is due to downstream effects on neurotransmitters, but clearly there's potential for concurrent permanent brain injury occurring at the same time as whatever is giving rise to the delirium, and maybe the two things are the same. We just don't know that yet. Now I'd like to just give a quick summary of what we do to look after people with delirium. So there's basically three processes that we have to try and achieve: detection of delirium, treatment, and prevention. So what do we do about delirium detection? Well, these are the DSM-5 criteria. DSM-5 came out in 2013, you probably know that. And these are the criteria, the first one being a disturbance in attention and awareness. So as I said, people with delirium are usually not able to have normal conversations. They may be able to get a few sentences out, but then their attention will shift, or sometimes they're just too sick, too sleepy to talk at all, often disorientated and so on. But the other critical thing is that delirium has an acute onset over hours or days, and it can fluctuate as well. The other two criteria are probably a bit less relevant for an acute hospital care, because there's usually going to be other disturbances in cognition at the same time if somebody has severe inattention, and also that we don't see too many other causes of delirium-like syndromes in hospital. Occasionally we do, though, like autoimmune encephalitis and so on, or brain tumours can sometimes present as a kind of like more subacute type of delirium, so you do need to look for these, but 95% of the time it's a straightforward diagnosis of delirium. And what we don't usually use DSM-5 directly, but use tools like the 4ET, which was developed in Edinburgh as a widely used tool now. And the nurse or the doctor who sees the patient is asked to just check alertness, do some cognitive testing, and then determine if there's any evidence of acute change through various sources of information. It might be a family member that's there, or it might be from the GP letter, or they might know the patient because the delirium has occurred after admission. So what about delirium treatment? This is a big topic, and I'm just going to show one slide and just talk quickly over it. So this is a framework that I use for delirium treatment, and it's quite complex and difficult to treat delirium properly. The first stage in the red box in the top left is to always consider the person with delirium to be very unwell, because they often are. So we look for things like a big dose of morphine that might have been given that's been essentially an overdose, or somebody may have low blood oxygen that needs quickly to be fixed, or high blood carbon dioxide, that kind of thing. So it's really an emergency when you first see it. Once that's been taken care of, then there's a whole other process of things that need to be done. Optimizing conditions for brain recovery, finding all the causes and treating them. I've mentioned distress. Delirium is frequently a very distressing condition for patients as well as carers. It's a condition with lots of complications, such as prolonged immobility, aspiration pneumonia. So people can be very sleepy with delirium, so they may choke on their food and inhale what they're eating and then get pneumonia, which can be very serious. It's very important, as I'll come to later as well, to communicate the diagnosis to the patient as well as their carers to make sure that somebody's recovering and so on. So it's a complex thing to deal with. It's a brain condition with a lot of medical and other types of causes. So it requires a team approach, really, with very good nursing care is at the heart of it, alongside medical care, physiotherapy, occupational therapy. It really needs a big team of people to do a good job of delirium care. And on to prevention. So this is one of the best evidence part of delirium care. And essentially, prevention involves avoiding harming the patient once they come to hospital, because most delirium is already there at the front door, so you can't prevent it. But in about a third of the cases, people who come in who then get delirium after admission, it's usually some kind of cause that you might have been able to prevent through making sure that, for example, somebody doesn't become dehydrated, or they don't become constipated, or they don't get the wrong drugs. And if you do that, all these things very well, you can present around a third of new onset delirium in hospital. But to be honest, quite often it just happens anyway because somebody develops a new infection, or they were on the way to getting it. But certainly there's no doubt that we should be doing this routinely in vulnerable patients, especially patients with dementia when they come into hospital. And I've summarised it by saying take care of the brain and the body when somebody comes into hospital. Now I'd like to move on to the topic of delirium and dementia. So just as a kind of summary to start with, delirium is without doubt a very strong risk factor for future dementia. We also know that dementia is a very strong risk factor for delirium, so the two are very strongly interlinked. To give you an idea of the scale, people with dementia come into hospital, and around a quarter of people in a hospital have dementia, which is an amazing statistic. Many people don't know that. So that's not just old people. If you take the Royal Infirmary in Edinburgh, where I work, of the 1,000 people here in the hospital, 250 will have dementia approximately. And around 2/3 of those will get delirium as part of their stay or have it when they come in. So it's an enormous problem, especially for people with dementia, given all its serious consequences. And it's often present at the end of life in people with dementia, almost, I would say, in the majority. And as we'll come to, there's quite good evidence now suggesting that there's overlapping mechanisms between delirium and dementia. So now I'd just like to cover some of the relationships that have been uncovered through epidemiological work. And I'm going to indulge myself a little bit by starting with this. I'm going to read it out in a second, but I actually went to the Royal College of Physicians library in Edinburgh and asked for this book to be taken out by the careful librarian, who then scanned in the page where this famous section is, because I'd only ever seen it quoted and I really wanted to see the book. So I'm just going to read it out. So, memoria deperdita, the loss of memory chanceth sometime alone, and sometimes reason is hurt with it. It is caused in the lethargy and other soporific diseases. It cometh to pass also that the soporiferous diseases being ended, there ensueth forgetfulness, which, when it chanceth then a cold distemper as a cause, that the memory is perished or grievously hurt. So amazing. This is written a long time ago, and it's essentially saying that people with soporiferous diseases, like I would say essentially that's a kind of delirium, in the context of an infective illness, even if the soporiferous diseases are past, that the person has, the memory is perished or grievously hurt. So this is a recognition 400 years ago that people with delirium may have lingering cognitive problems after the delirium has resolved. And the first major confirmation of this actually came quite recently in a paper published in 2012 led by Daniel Davis, who's now in London. And this is an amazing study where Daniel took a whole cohort that had already been recruited and studied, but looked for evidence of delirium. And Daniel found that in people without baseline dementia, episodes of delirium were associated with an 8.7-fold risk of dementia in the 10-year follow-up period. This has been substantiated by multiple studies, but this is an interesting related study in a memory clinic population where patients were followed, the records were examined, and those who'd had episodes of delirium had an accelerated decline in their memory functioning. These are all patients with memory attending a memory clinic. And another study, just there are many examples, but this is another interesting study of people, of taking people with Alzheimer's dementia. And this is a memory clinic population, again, the same population, but this time they looked more closely at hospitalization, because when people are hospitalized, obviously they're often going to be quite unwell. It's not just elective surgery, it could be quite serious illness. And so it's that risky time when somebody may be ill, but they also may be having this period in hospital, which is associated with other brain threats to the brain. And inevitably in this cohort, hospitalization and delirium both increased mortality and new institutionalization, so new care home admission. And in those who survived, the cognitive decline at 1 year was much worse than those who'd been hospitalized, especially those with delirium. And I want to just point out as well that in this population of 771 people, that half of them had been hospitalized in the follow-up period. There's also supporting evidence from the intensive care world, and this very important study published in the New England Journal in 2013 found that patients who, of all ages, it wasn't just old people, and almost all of them didn't have dementia before they came into hospital, that a year after surviving critical illness, 1/3 had dementia-level cognitive impairment. And this hasn't been studied all that well in terms of brain imaging, but I just want to give a couple of examples. This is just case examples really showing people in their young middle age, 46 and 42, both with pneumonia and acute respiratory distress syndrome, one with delirium, one without. And you wouldn't expect somebody of this kind of age to have atrophy, as clearly shown in this slide here. But this is commonly seen, that people who've been unwell, especially when they've had delirium, often have visible brain damage on their scans. And this is a single person who, and this shows progression of white matter disease during a case of pneumonia. And these are just a couple of examples. There aren't that many imaging studies, unfortunately, partly because of the difficulty of doing imaging during delirium, and also because it's an unpredictable event. So we don't have many cohorts where we have imaging before the delirium occurs and then are able to follow it up. So this is a summary just published in February this year, which this summary found 12-fold odds ratio risk of dementia following delirium. And I think you might be able to argue with some of these studies, but there's multiple evidence now, pieces of evidence now showing that there's a strong relationship between episodes of delirium and risk of dementia. What we don't really know, though, is why this might be. And people have speculated, and I think probably the most common speculation up until quite recently has been a kind of, if I don't mind me saying so, quite a lazy speculation that the dementia pathology was there anyway, the delirium simply just uncovered it, and the fact that they got dementia in the future was just because it was going to happen anyway, and the delirium just exposed it was going to be happening. That's why there's a relationship. But that completely ignores other possibilities. It's not a very scientific approach just to make that assumption. It's actually better to take an agnostic approach and then to try and study whether there could be the possibility of brain injury when somebody's unwell. And as I've shown you in the last few slides, there's good evidence that that could be the case. And then say, well, delirium is a marker of current brain injury, so delirium might be itself, whatever is the delirium process is, might itself be damaging to the brain. Maybe there's glutamate excess, who knows, maybe there's too much dopamine swimming around, maybe there's synaptic change, we don't really know that. Or maybe whatever is causing the delirium, like low blood oxygen, is also damaging the brain at the same time as the delirium, and independently there's brain damage happening at the same time. It's just a marker of vulnerability. There's lots of different ways that that could be happening. We don't really know the answer to that. So just as a recap to think about possible two channels of mechanisms that we might be considering: direct brain insults and aberrant stress responses. So I'm just going to go through a quick run through some examples that you might see in the literature and in clinical practice. So this is two charts from two different people undergoing surgery, and normal blood pressure, as you probably know, is about 120 over 70, over 80. In older people, it's actually a little bit higher, usually 140. And so these are in 2 old people with hip fracture, and you can see that the blood pressure on the left, the systolic blood pressure, dropped down to 70 at one point, which is very low indeed during the operation. And on the right, there is a drop from 150 down to about 100, which is a bit of a drop as well, but not so severe. Multiple studies now show that that's probably, especially in animal studies, that's probably going to be associated with brain injury, or there's a good chance of it at least. And in fact, there's beginning to be some evidence of this. This is in ICU patients, showing that those who had episodes of low blood pressure had a high risk of delirium. Moving on to stress and inflammation. So this work might be familiar to you. So Colin Cunningham is a distinguished scientist working in Dublin, and he discovered, along with some other people, microglial priming, and published this a long time ago. And striking results, which really have a lot to say, I think, potentially to the idea that acute illness can affect neurodegeneration and progress it further. So in this classic experiment, Colin took prion diseased animals versus controls, and he injected lipopolysaccharide peripherally and found that in the animals with the prion disease who had primed microglia, as it became termed, produced interleukin-1 beta, neurotoxic pro-inflammatory cytokine. And it's been shown in multiple other studies now. And this is another set of experiments showing that if this is done in a recurrent way, on the background of neurodegeneration, that you see cognitive decline, which increases with the number of systemic inflammatory events. Notably, the brains that are healthy didn't show this decline. So we tried to study this in humans. It's obviously much more difficult to do it. And this is one of our early studies where we took CSF, cerebrospinal fluid, at the time of surgery for hip fracture. So most people with hip fracture in Edinburgh get spinal anesthesia. So they have a needle put into the base of their spine and the anesthetic's injected. So just before the anesthetic was injected, we asked the anaesthetist to withdraw some CSF, and we measured delirium pre and post surgery. And this type of technique is done a lot now to try and understand possible CSF markers of delirium in hip fracture patients who are quite prone to get delirium. In around at least a quarter up to half in some centres get delirium around the time of surgery, pre or post. Anyway, so in this early study, we found increased interleukin-8 in the CSF in patients with delirium versus those without. And I'd like to talk about stress, and I think this is something that perhaps hasn't been covered enough in the research world, because when you think about an old person in hospital, especially in the COVID time when we couldn't have family visiting, many of these people were in hospital for a long time, totally isolated. Of course, the nurses and doctors were trying to be friendly and keep them company, but many people were just alone for hours and hours and hours, often sleeping badly, in pain, frightened, and especially with dementia, you can imagine what a devastating experience and stressful experience it could be in hospital. And there is actually some animal model evidence that psychological stress alone can lead to changes in the brain. For example, in this study, where isolation stress increased amyloid deposition. And with respect to humans, this is an old study, but one I think that is really interesting still, that 8 weeks after hip fracture, some people with worse recovery had really quite high doses of cortisol after. So this is another possibility that either the stress is causing the high cortisol, or there's some problem with cortisol regulation such that the levels stay high for a long time. Other studies have tried to look at other markers in CSF. This is one without a control group. That is, there was no group with acute illness and didn't have delirium because the lumbar puncture was done not in the context of surgery, but actually to investigate the cause of the delirium. But the levels of lactate were pretty high, and there's a couple of other pieces of evidence now showing that this could be the case in patients with delirium, that they have some problems with oxidative metabolism. Astrocyte activation or possibly CNS injury. This is another one of our early studies. Again, the numbers are pretty small, but evidence of perhaps increased CSF S100B. And this very recent study just published, quite interesting, showing that neurofilament light, which is a more recently studied marker of brain injury, it's certainly up in some cases of dementia and many other causes of brain injury. But in delirium, and this is important because they were able to measure plasma neurofilament light and show increases over time in patients with delirium when at a baseline there were no differences. So this is quite an interesting study, and I think we might be hearing more about neurofilament light as time goes on, especially in relation to longer term outcomes. So that's the end of this section on mechanisms, and I'd just like to refer you to this paper, 10,000 word review that was published in November. I'm one of the co-authors, but I didn't have much to do with the pathophysiology section. That was written mostly by Colin Cunningham that I mentioned, and it's a really good up-to-date account of all the work that's led up to some of these conclusions I presented today. So just to conclude with some thoughts on what this all means for how we look after people in hospital with delirium and dementia now. So unfortunately, delirium remains an area of medicine that's not practiced very well, that we don't detect delirium that well. Scotland's actually better. It's one of the best countries in the world probably now for delirium detection. I would say at least half of it's detected now in Scotland in general. But not great at treating it. We don't have very good systems in place because it's a complex and difficult condition. The treatment's usually incomplete or completely absent. Maybe just somebody picks up that they've got a pneumonia and they treat that, but no specific delirium care is actually given in many cases. And even though we know we can reduce the risk of delirium occurring after admission, there's not much to say that we're systematically implementing these strategies. So I mentioned before all the different ways that the brain could be compromised during a person's stay in hospital, especially when they're unwell. Some of them are listed there. And so I think we really need to be thinking that when somebody comes into hospital with delirium, especially if they're older, and especially more if they've got dementia, that their brain is really under great risk of being further damaged and having worse outcomes, as we've seen from these epidemiology studies. So it's just a question really of attacking all of those different variables as well as you can when you see a patient in this kind of position. So protecting the brain through making sure the oxygen levels are good enough, avoiding low blood pressure, treating infections promptly, that kind of thing. I think managing communication is really important. We need to use the word delirium and tell people you have delirium or you had delirium, and explaining it carefully, giving them a leaflet. This is one of the ones that were produced by Healthcare Improvement Scotland. It's an excellent leaflet, it's freely available. Also, I think we now have good information that if you have delirium, you've got a risk of future dementia or worsening of dementia. Whether that gets built into clinical practice is another issue, because it's quite an awkward conversation to have, and people might not feel secure enough at the moment to do that. But I've certainly seen evidence of that in some colleagues in geriatrics in Edinburgh, that when delirium is happening and a conversation with the family is occurring, that we say that, you know, your loved one has delirium, they've had it for a few days now, we're very much hoping that it'll get better, but sometimes people don't fully get better and they may not return to their original, to how they were just before. Also, it's definitely quite a serious prognostic sign, as we've said. I think also, because we know that delirium is associated with dementia and not all dementia is diagnosed, that it's a marker for possible dementia if there's no diagnosis of dementia and it's an older person. So the IQ code, the informant questionnaire for cognitive decline, the elderly could be used in that circumstance, or if there's evidence of some cognitive decline pre-admission, that some kind of setup is put in place to, for example, for the GP to see the person 3 months later and find out how they're doing, or refer to an old age psychiatry clinic. So this work that Thomas Jackson in Birmingham led found that there was quite a lot of undiagnosed long-term cognitive impairments, usually dementia, in people with delirium, and also that IQ code was effective at picking it up. So what about the research implications from all this clinical work and this epidemiology? Well, I suppose the request I'm making, or the plea I'm making, is that that delirium just becomes more integrated into dementia, the dementia research body. It's included in epidemiological studies. So instead of seeing dementia as being a steady progression, a curve, you know, these smooth curves that you see of amyloid accumulation, of tau tangles accumulation, these kinds of things, or vascular lesions slowly accumulating over time, and why not look for episodes of hospitalization, episodes of delirium? That's quite a hard thing to do. It was quite a hard thing to do in the past. It's much easier now because of electronic healthcare records. And in fact, in Scotland, we're getting better at detecting delirium with the 4ET, for example. So, for example, in the Royal Infirmary in Edinburgh, we have 77% completion of the 4ET at the front door, with a lot of delirium being detected automatically now in routine records. So, you know, if you're doing cohort studies in Scotland and in England as well, actually England's quite good at it as well in some centres, you may just have delirium already being diagnosed routinely in clinical care, instead of it being a more difficult thing to find because in the past it was underdiagnosed. I think also, if you are studying trajectories in dementia and somebody's been hospitalised, go further than just saying they've been in hospital. Find out how they did in hospital, measure things that might have happened that might have affected brain health when they were in hospital. I think that's a really important thing to integrate, because, you know, the quantity of effect size, the effect size is probably quite big. I mean, we're talking about 8 to 12-fold risk of future dementia in the context of delirium. We're seeing obvious brain damage in people who are very unwell in ICU, for example. So this could be a big part of what we're seeing, you know, a big cause of dementia or worsening of dementia that's just been missed, you know, by much of dementia research, I'm afraid to say. I think also animal model research is going to be very important. Some of Colm Cunningham's work's been really fascinating. For example, he's found that in sapperin lesioned mice with a bit of, so some cholinergic function was removed, about a quarter of it was removed, that donepezil, cholinesterase inhibitor, protected the animal from lipopolysaccharide-induced cognitive decline, acutely and chronically, and also that ibuprofen, a non-steroidal anti-inflammatory drug, also seemed to mitigate the effects of lipopolysaccharides. So this is really interesting, isn't it, in terms of the possibility of having agents that could influence the amount of damage that's happening to the brain. So, as I say, I think there are lots of opportunities here, probably not quite just yet, but hopefully on the horizon we will be able to think about protecting the brain using drugs in patients in hospital. But I think the first step is going to be to optimize general care first. I think there's no point in giving fancy drugs if we haven't managed to make sure that somebody isn't, you know, hypoxic or got a low blood pressure for ages in hospital. It would seem to be that is the platform upon which you would then test other agents. So just to conclude now, I hope I've managed to persuade you that the two conditions are very closely linked, that delirium is a really common condition. It affects nearly all people with dementia will get delirium at some point in their lives. It's just been missed. I mean, I'm sorry to say that in a recent otherwise excellent review in the Lancet Neurology, I think by Shelton's, the Alzheimer's disease seminar, I think it was called, delirium didn't appear once in that whole, it's not even, you can't search for it, doesn't appear at all in that whole long article, not even listed as a risk factor. So there's a real problem with crosstalk between the two fields. So we really need to fix that. And I think if that happens, then I think it opens up new possibilities to understand this complex condition called dementia, where clearly beta amyloid and tau are part of the story, white matter disease, other story, but probably there's many other mechanisms. I'm not an expert in this at all, of course, but, you know, inflammatory causes, which could be tied into acute illness or bursts of acute illness, and open up whole new avenues of not only prognostication, but also possible therapy. Another thing in terms of if you're dealing with the clinical side of dementia care, so telling people what's wrong, of course, BPSD, if that's still what it's called, or behaviours that challenge or whatever, is something that's a big part of good dementia care, understanding that and dealing with it well. But it could be delirium in many cases, and it could just be missed. And I've certainly seen that as a doctor, that things have been wrongly attributed to BPSD when it's been delirium. So I would recommend this review if you're interested, this long review that was published last year, which has a summary of the whole field, especially the pathophysiology. So I'll leave it there, and I'm very happy to take questions. Thanks very much for your attention.
Thanks very much, Alasdair. That was a really interesting talk, and I have learned so much in the last 45 minutes or so thank you. And we've got some questions starting to come in. The first one is from Ariel Frame. You've spoken a bit about that. Is there any way to model delirium in animal models?
Yes, I mean, there's a lot of work being done on this now. Colin Cunningham has been the main person who's done this, and what he done originally was with prion diseased animals, and he gave medium doses of lipopolysaccharide. Some people have given really big toxic doses that would potentially even lead to the death of the animal, so he didn't want to do that, and he gave smaller medium doses, and this caused short-term cognitive impairment. He's got various cognitive tests, TMAs. In some cases, the animals have been trained to do these tests, so they knew you could do them, and they couldn't do them for 2 days. Then they would recover and go back to normal. But then, very intriguingly, he would see that over time they would decline in their performance a lot faster if they'd had the LPS compared to the prion animals who'd been given vehicle. So yes, that's one example. There are many others that have been done, but I would start with Colum's work as a starting point to look at how we tried one actually using stroke-prone spontaneously hypertensive rats, but it never really went any further. But I think there's huge potential for other models. Another piece of work that I was involved in peripherally was using animals with a tau model of dementia, and these mostly had motor problems rather than cognitive, but again, lipopolysaccharide caused motor difficulties which resolved within 2 days, but then the animal showed a progression of this. And this is actually fits quite well with our understanding of delirium as being a condition. Yes, it affects cognition in the brain more, but it can affect mobility, falls, other things, other parts of other functions of the brain can be affected as well, other parts of the nervous system. So it's highly relevant work, and I'm sure that benefits of this will be realised in due course.
Thanks, Alasdair. We've got another question here from Margaret Brown. Margaret asks, should it be advised not to stop acetylcholine esterase inhibitors in people with dementia admitted to acute care and at risk of delirium?
Yes, I'd certainly say you shouldn't stop these drugs unless there's a good medical reason to stop them, like a cardiovascular reason. And it's often done, I think, with good intentions, but I think that mostly it's a bad idea to stop these drugs. In fact, mostly I don't stop chronic psychotropic drugs of any sort when somebody comes into hospital unless there's a very good medical reason.
Okay, thanks. You've got another, just a point really made by Stephen Macon, who says that, I've lost it here. Mementine can cause delirium, so I do struggle to know what to do with it.
Yes, well, certainly I've seen mementine causing drowsiness and, somebody going off a bit. So it's a drug you just have to watch, but I would probably mostly not stop it unless there was absolutely no other reason, in which case I might reduce it rather than stop it. But if it's associated with starting the drug, it might be that even with a 5 milligram dose, it might be that person just isn't going to tolerate it.
Okay, thank you. Question from Anna Jacquot. Would you advise, the questions keep moving. Where does it go? Would you advise that an incident of delirium makes the person have a future increased risk of another episode of delirium?
Yes, that's well established that it's a risk factor for future delirium previous history, which is another reason that's very important to document, you know, in the medical records when somebody has delirium, and communicate that to the GP.
Okay. Question from, or a point from Lorna Walker. It may be interesting to note how we can assess the impact of loneliness and the impact of COVID. Maybe work for the future may include more human interactions. Magic medicine may not be enough.
I really love that point, and in fact, I had a very powerful experience about 2 weeks ago during World Delirium Awareness Day, where 3 people who'd had delirium were speaking about their experiences, and other people have said this kind of thing to me as well, that how they were treated, how they were spoken to during their hospital admission had a huge effect on how they felt, and years later they remember, you know, whether somebody just treated them in a kind of functional sort of a way, like here's your water, goodbye, versus somebody who knelt by the bedside, looked them in the eye, held their hand and said, hello, and then giving their name. I'm sorry that you're having such a terrible time. What can I do for you today? Can I bring, you know, can I phone your husband? Or, you know, these interactions are really, really important, and they're much more important, I think, than we thought. And I think we thought that maybe just handling the medical side and providing, you know, hydration and nutrition was enough. Actually, people with delirium are often in an awful position mentally, and no doubt staff, in the absence of family, staff have a very important role to be kind and to tell people what's going on. In fact, one of the patients in that video said, you can't be too orientated. And I thought, what a wonderful, you know, statement that was. You know, so constantly just telling somebody in a nice way, you're in the Royal Infirmary, this has happened to you, you've had an operation 3 days ago, it went well, you've not been yourself because, you know, various reasons, we think you're getting better now, don't worry, things are going to be okay. That can make a massive difference to somebody's experience, no doubt about it. So that's about managing stress. You know, I think the stress of isolation, and I showed that slide in the animal model, you know, where stress can cause real effects on the brain, there's no doubt about that, and especially prolonged stress. So I really totally agree with that, and I'm hoping that that's going to be something that we get better at in the future.
Great, thank you, Alasdair. A question from Margaret. For families with no diagnosis but alcoholic brain injury, capacity but memory impairment, can delirium resemble false allegations?
Well, delirium is very heterogeneous. So part of delirium can sometimes be paranoid ideas. Sometimes it can be a mood change. So people with delirium can feel anxious or sad as part of it. I've seen that a few times. I think it's very difficult, to be honest, and I think you have to be awfully careful with these kinds of situations. Usually my approach would be to try to do my best to understand what's being said, to involve all relevant parties, but also not to work on my own. So I would usually, I'm a geriatrician, so I would usually ask a colleague from psychiatry to help, because they're usually more experienced and expert at this kind of situation. And not to draw conclusions quickly is something I've learned as well. Is always to try and just get as many facts as you can, and take good notes.
Okay, thank you. We've got another question here from Catherine Pennington. Is there a hard biological definition of delirium? My understanding is that, like dementia, it is essentially subjective and based on a significant change from baseline behaviour, which can be hard to make when the person has pre-existing dementia and is now in a strange environment and the staff don't know them. That's
right. So there is no hard biological. There is promising work on EEG, and I think some will probably in the future have quite efficient, simple EEG that will show changes in some cases of delirium, especially severe delirium. Apart from that, we are just left with careful evaluation based on what people who know the patient tell us is very important, especially in the context of dementia, where it can be hard to tell. And I do believe that there are people who come into hospital with dementia, especially if they've been living in a consistent place for a long time, like a care home. You know, they come in, and hospitals are really hellish places, you know, in terms of the noise and disorientation, changes in temperature, you know, people often ask me to close the window because they're freezing cold, you know, that kind of thing. You know, they can't reach for drinks properly. They're ill as well, you know, so that also makes it quite difficult. You know, that it might just be you know, that someone's frightened, and then they start calling out and shouting for help, and it's not really a delirium that you need to say is caused by urinary tract infection. It's a stress-related delirium, and I'm certain that is one of the causes. But I think delirium is really a descriptor. It's a starting point, and I think it's a really useful starting point. I advocate that it is used even when you think that it's just a change of environment, because what it then requires is a therapeutic response that involves a careful analysis of the possible causes and not making assumptions, you know, that this is, you know, I mean, you could easily say that somebody it's because they've just moved from a care home. And in fact, what you've missed is that they have 10 days of constipation, or they've just been started on dihydrocodeine and they're poisoned by that, and that needs to be stopped. You know, I mean, there are tons of times I've seen people with clear medical causes, and it's been written off as somebody with dementia who's just reacting badly to the environment. So I think it's a delirium is a starting point, and then you have to then use all your careful analysis of all the factors and take action from that. Certainly, you don't reach for an antipsychotic drug, though. You know, as soon as somebody is expressing distress, that's a big mistake.
Thank you. Okay, another question from Anna Jack Wall. Are you continuing to recommend the single question in delirium to support assessment with families?
Yeah, so the single question delirium is interesting. We just did a survey of UK units, and it's used in a third of UK units now, and it's not all that well validated, the SQUID, in an academic literature, but it's interesting because clinically people have just started to use it because they like it and it seems to work. So I think we need to do some more evaluation, but it's certainly a lot better than not doing anything. And I think if you use the SQUID with a family, when somebody comes in, if a family knows to give a clear, you know, impression, that's something that needs to be tested, you know, because we don't know if families give accurate information about onset. We assume that they do, but, you know, for example, if the informant doesn't know the person very well, that happens quite a lot. People live in a different part of the country, they haven't seen them all that much, you know, how the question's asked, you know, so I think it's a helpful measure as part of an overall approach, I would say, and I would recommend that it probably is used at the moment, because it's just got such good face validity. You know, it's at the heart of what delirium is, the change in somebody's behaviour, and the studies that we do have do support that it works quite well if the informant knows the person well enough and is able to give a clear history. But I wouldn't rely on it completely, and certainly I would never advocate where that's your only process, because lots of studies show there isn't an informant available, and what happens is that nothing happens. Sorry, no, you know, there's no informant, no SQUID, we just stop. That's why, I mean, I know I'm biased because I'm one of the authors of the 4ET, but the 4ET allows other routes to a delirium diagnosis that doesn't rely entirely on having an informant in front of you in the ED, which is only, you know, that's probably a good quarter of people don't have an informant in the ED.
Yeah. Okay. We've got time for one more question because we need to finish at 7. So we have one more question from Jenny Gabriel. If hypoglycemia is a risk factor for delirium, is there any data on the relationship between poorly medicated type 1 diabetes and delirium and dementia in later life as a measure of cause and effect?
That's a really good question, and I'm afraid I just don't know the answer to that. I remember there being a lot of work on hypoglycemia episodes causing potential cognitive impairment in the future, and I know that there is evidence that, not that commonly and maybe underdiagnosed actually, but that delirium is a consequence of hypoglycemia in type 1 diabetes. What I'm not up to date on, and quite like it when a Q&A exposes a gap in my knowledge, you know, I don't know if delirium caused by, you know, hypoglycemia in a type 1 diabetic has been studied properly in relation to dementia risk in the future, but it's a really important question. You know, quite a lot of that work, original work about 20 or 30 years ago, was done in Edinburgh by people that I know. but I haven't. Maybe because type 1 diabetes isn't so common in my older age group. It's not seen so commonly. So, but it's something I'll look into. And thanks for the question.
Thanks very much. Okay, everyone. We do have another couple of questions, but we have run out of time, unfortunately. I'm sure you'd all like to join me in thanking Alasdair very much for coming along this evening, giving us a fantastic talk and for answering some tricky questions. Thank you very much, Alasdair. Our next SDRC webinar will be on the 5th of May, and that will be on stroke. So thank you very much for coming.